And what I'm going to do is to take you through delivering these innovations that we have seen so beautifully represented. Now let me get this slideshow. How do I get that? Here. Oh, to the right, sorry, yeah. So when Mamta asked me to do this talk, I thought, I looked at the title, and my initial feeling was that, this is going to be a very short lecture. Because as a clinician, we're often frustrated by the fact that we cannot get novel technologies as early or as soon as we would like. But delving into this talk, over the last 2 weeks, what I've discovered that actually my answer today is very different to what it would have been 2 weeks ago when I started doing the work for the lecture. And what I'd like to do is to take you through this journey of discovery about delivering innovation. So, of course, the first thing, if we're going to deliver innovation, is to ask the question, what is innovation? I didn't know what innovation was. How is it defined? I know it's technology, I know it's an idea, but what do you do with that idea? So innovation isn't just the idea, it's about you and I implementing that idea and the processes, and this is the key thing. The key point is the third point. It's the implementation of ideas and processes that improve healthcare for patients. And I lived in this ivory tower that I thought that if you do procedures and treatments to patients, that was innovation. No, innovation occurs across the whole spectrum of healthcare, and I will come back to this towards the end of the talk. Innovation is about striking balance. All of those fantastic achievements and technological advancements that you heard in the earlier talk, they've all undergone a battle, okay? And it's important that we recognise that when we innovate practice, in order to bring it through, there are conflicting views. There's the yin and the yang. So we're all familiar with, as I said, people who want innovation early, and those voices that are saying, no, there's not enough data or it's too expensive. And the King's Fund put this very nicely in this quote. Ask too much or give too few opportunities for real-world testing, and we risk protecting an outdated status quo. So if you say it's too expensive, there's not enough data, we can't bring this here, we don't have the expertise, you risk not changing medical practice and leaving the status quo in the face of technical advances is a sin, because technological advances is what has led us to produce effective care. You've heard today from big open heart surgery to percutaneous surgery. That's through technological advances. But the other extreme is that you ask too little of the new technology, and you risk spending public money on a treatment that is ineffective. So you have to have the balance, you have to have the checks and balances that allows innovation, innovative practice at the right time. You've seen this, Mamta's presented this, but these were some of the top 5 interventional innovations that were presented at the American College of Cardiology meeting last year. Can we have it all? Well, we have to go through a process, but these are some of the things that are being tested in cardiology at the moment. I've presented what Mamta has talked about in a different way. What is innovation in cardiology? Typically, we start off, and this is an example of the valvular heart disease that you've seen, but it's worth going through this, so that when patients developed valve disease, the only treatment 10 years ago was what you see at the top there, surgical, and we're talking about aortic valve replacement, AVR. That required general anesthesia. It was resource intensive. It took a lot of staff to man the theatre. Patients were recovered on the intensive care unit. It took a lot of staff on the intensive care unit. They stayed in hospital for 4 to 5 days. It was hugely resource intensive. In the last 10 years, we have come with this percutaneous approach called transcatheter aortic valve replacement. Now, the problem is that the percutaneous approach, the valve, is actually 5 times more expensive than the surgical valve. So we had a problem to convince the commissioners, to convince the healthcare business community that the percutaneous approach would be cheaper. It's certainly easier for patients, but the innovation was that we went from a surgical open heart surgery to this percutaneous approach. The next innovation was this second arrow that you see below, where we started performing the procedure not under general anesthesia, but under local anesthesia. The next innovation was that these patients, instead of staying in hospital for 4 to 5 days, are now going home the next day. And continue that theme. What will happen eventually, I hope, is that we will have a medical treatment for this condition that will no longer need a valve implantation, either percutaneously or surgically. And if you plot the same chart for atherosclerotic disease, we are seeing this transition. We're going from surgical coronary artery bypass graft surgery to percutaneous coronary intervention, general anesthesia to under local anesthesia. And now, just yesterday, there was evidence that these new PCSK9 inhibitors are the first class of drugs to show a regression of atherosclerotic disease. And that was a study that we were involved in. So it's possible that when I give this lecture to you next year, if I'm asked, that we now have a medical alternative to coronary atheroma. That is innovation. And what I want to talk to you about is how can we bring this innovation into daily practice. So what I said to you earlier is that as a clinician, we see, particularly in cardiology, we are blessed in having interventional innovation. But innovation takes many, many guises, and this is what I've learned in the 2 to 3 weeks that I've spent looking at this topic. It's not just about the fancy interventions, the fancy operations, or the fancy tablets. It's also about digital technology. And not only about digital technology on your smartphone, getting information about the patients that's come directly to the hospital so the patients don't have to go to hospital. There are pilot studies in Australia where we're able to take diagnostic tools that previously and currently exist in hospitals, like X-ray machines, ultrasounds, blood testing kits, into patients' homes. That is innovation. It's taking the diagnostic kit into the patient's homes, it's saving patient journeys, it's allowing the hospital facilities to be used for more trauma cases or more acute cases or for admission cases. So this is innovation, and we're seeing this in cardiology. So if I have to answer the question, can we have it all? You know, I know that the answer to that often is no. And the reason it's no is because the people who hold the budget, the commissioners, quite rightly look to see whether any innovation, technological innovation or pharmacotherapy has a cost-effective ratio. Okay, they look at the cost-effective ratio. Whereas we as clinicians tend to be focused on the efficacy alone, the commissioners, quite rightly, and any healthcare system has to be focused on the cost efficacy. I'm not a health economist, but this is the a chart that was drawn for the TAVR, the percutaneous aortic valve. And essentially, what health economists, what commissioners want, is a cost of efficacy that sits in the bottom right quadrant. So you have benefit to the right, and you have reduced additional cost, which sits low on the y-axis. Very few medical advances sit in the bottom right quadrant. In this example of the aortic valve, it sits in the upper right quadrant, so it's essentially expensive but effective. So when the TAVRs were first brought out, there were a limited numbers of centres that could do it. As the price of the device, and this is another thing that you and I need to realise, is that once technology is adopted, the price falls. We've seen this with coronary stents, we're seeing this with aortic valves. So whilst there is a barrier to implementation which is based on cost, once the technology is taken on board, as it increases, the cost comes down and the cost to the health service comes down. But the cost to the health service comes down in other ways because, as I've said earlier, for this particular technology, patients can be done under local anaesthesia. Instead of having a theatre full of staff, it has a cath lab that maybe has 3 or 4 people. Instead of recovering patients on ITU, patients are recovered on a regular cardiology ward and go home the next day. So the cost saving to the NHS, not just in terms of money, but in terms of resources, are huge. And this is what innovation does. Innovation saves not just improves patient lives, it reduces healthcare resource and allows us to use that resource for other things. So innovation has to sit alongside service delivery, and that's the important thing. So how can we bring in innovation into not just into cardiology, but into other specialties alongside the service delivery? And this is my journey of discovery. What I wasn't aware of is how many different programs there are within the NHS umbrella that allows you and I to develop innovation and to put it into practice. The key thing is that the NHS currently has a 5-year forward view. And the core principles of this 5-year forward view are, it won't surprise you, that we close the health gap. There is a huge health gap amongst the wealthy and the poor. We know that. There is a gap between the quality of care that is offered in certain regions. There is what's euphemistically known as the postcode lottery. There is, based similarly again on the postcode lottery, there is a funding and an efficiency gap. And the 5-year forward view of the NHS seeks to close these gaps in healthcare delivery. And if you take nothing away from my lecture today, absolutely nothing, take away this. There is this pamphlet, it's a booklet actually, from Innovation into Action. And Innovation into Action is an NHS concept that tells you and advises you about the many ways that we can bring innovation